Good evening once again. Welcome back to my YouTube channel. I'm just reminding you to subscribe, hit the notification button so that anytime a new video lecture is uploaded, you are among the first people who receive the information. Today, our topic is going to be chamber enlargement or hypertrophy, cardiac chamber enlargement or hypertrophy, and how they manifest on the 12-lead electrocardiogram or ECG. Before this topic, we had completed anything about the normal ECG, how the normal waves are formed, and the naming of all the waves, intervals, and the segments, and all their durations and morphologies. We finished that. So today we are starting the clinical electrocardiography, where you're looking at abnormal ECGs. Today we are looking at abnormal ECGs. In this lecture, I'm just going to explain simple things about enlargement, the causes and the types, and then the clinical part, we are going to use the real ECGs to find these enlargements. So we are starting. Remember, we said the heart is a four-chambered organ. It has two atria and two ventricles. So if we talk about chamber enlargement, we are meaning the enlargement of these four chambers, both atria and ventricles. So what is enlargement? Enlargement, as we have noted here, the same as hypertrophy. Two types of hypertrophy is there. This is not medicine, it's not pathology, but just as a reminder, types of hypertrophy is there. Types of hypertrophy is there. We have eccentric hypertrophy and the concentric hypertrophy. Eccentric hypertrophy and concentric hypertrophy. Eccentric hypertrophy, what is eccentric? Here in eccentric, the size of the cavity increases. If this is the ventricle, like for example this is RV and these are the walls, like this is RV and this is normal. If we have eccentric hypertrophy, it is going to turn into like this. So this is the myocardium, the RV free wall. This is the RV free wall. So what is the difference? The difference is cavity size. RV. This one in 1 and then 2, the cavity in 2 is larger than the cavity in 1. So for this case, if it happens like this, it is eccentric hypertrophy. This one is eccentric hypertrophy. In eccentric hypertrophy, the thickness of the myocardium, this is wall thickness, may remain the same or increases in size. But in concentric, if this is the chamber, and it's the normal RV, again I'm using, this is normal. In concentric, it is going to So cavity, RV cavity. In concentric hypertrophy, the cavity size is going to reduce. This is concentric hypertrophy. This is eccentric hypertrophy. So this is the whole thickness. So when you go on ECG, these are simple things. I'm just saying, I'm not going into depth. These are things you are going to see, and then the changes shall be looking at for on the ECG to be because of this one. In eccentric, the wall thickness remains almost same, or it just might increase. And then in concentric, the wall thickness, it is way thicker compared to this one. So the thickness, wall thickness in 1, so that one in 2 is way bigger than this one. And then here, it's almost the same. So what do we expect? In concentric hypertrophy, remember when we were doing the basics of ECG, we said a larger myocardium generates a larger, remember, the thicker the myocardium, the higher the voltage it produces on depolarization. The thicker the myocardium, the higher the voltage it produces on depolarization. What does it mean? Like the voltage, this one is going to produce more voltage compared to this one, and then this one, it may stay the same. It may be the same here in this position, this eccentric hypertrophy. Yes, concentric and the eccentric hypertrophy. So now the question is, why concentric and why eccentric hypertrophy? So why concentric hypertrophy and why eccentric hypertrophy? If we look at the etiological agents, the causes of concentric hypertrophy or causes of eccentric hypertrophy, we just try to remember back in the last lecture about myocardial mechanics when we were talking about the normal cardiac cycle. We finished the cardiac cycle, and then we talked about determinants of myocardial performance. One thing we talked about, it was the preload and the afterload. The things we talked about, those two things, preload and afterload. So we defined the preload as, most importantly, the volume of blood in the chamber just before it contracts. And then afterload is the forces against which the chamber, or the force against which the chamber should act to push the blood, or the forces that must be overcome by the chamber before the actual ejection starts. That is a proper definition. It must be so. In those ones, we will still carry our eccentric hypertrophy. Eccentric hypertrophy here. And we'll try to look at the causes. Since we said in eccentric hypertrophy, cavity size increases, meaning if the volume increases, meaning whatever was going in that volume, it should have been more to cause expansion. So preload, increased preload, and that is blood volume. So when does this one occur? like in valvular lesions, like regurgitant lesions, regurgitant lesions. This is when we normally have volume overload, like MR, example, mitral regurgitation, tricuspid regurgitation, aortic regurgitation, and the pulmonary regurgitation. These ones, they are going to cause increase in preload any chamber, whether it's LA, whether it's RA, whether it's RV or LV. Another one can be shunt, congenital shunts, for example ASDs, PDA, VSDs. These ones, they are going to increase volume in one chamber. For example, if we have a VSD, ventricular septal defect, blood will be, depending on the pressure differences, blood will be coming from either LV into RV. So what will it mean? What does it mean? That RV will be handling excess amount of blood, and then with the time it will dilate because to expand to accommodate that increased amount of blood. So eccentric hypertrophy, remember I said still in that last lecture of physiology, hypertrophy is a compensatory mechanism. It is a compensatory mechanism to something, either because of increased preload or increased afterload. So next is going to be concentric hypertrophy. What are the causes? The causes of concentric hypertrophy, that is increased afterload. And what was the increased afterload? That is, for example, blood pressure, the pressure to which, like aortic BP, that one. So the causes can be increased afterload, for example, systemic hypertension, and then valvular lesions, stenotic lesions. Stenotic lesions like aortic stenosis, mitral stenosis is going to cause this one. So MS, TS, they will cause this eccentric, but also at the same time they will cause concentric. MS, TS, PS, pulmonary stenosis, tricuspid stenosis, mitral stenosis, aortic stenosis, and systemic hypertension. And then some parts which are congenital, we don't need, like hypertrophic cardiomyopathy, and then here it's going to be dilated cardiomyopathy. Hypertrophic cardiomyopathy, dilated cardiomyopathy. And then the other ones can be infiltrative disorders. We're not mentioning anything. So these are the simple causes. So whenever you find on the ECG one of these ones, either concentric hypertrophy, like enlargement, you should think of these ones, these causes, that this patient may be having this. But most importantly, this we can find from echo. ECG is not a confirmatory test, exam. It doesn't, sensitivity is very low and specificity is also low. It doesn't confirm anything. It is just one of the investigations, the very basic, the starting investigations. If you want to confirm this, then echocardiography is the choice. Echocardiography. we have to do. We can decide whether it is eccentric or concentric. Otherwise, here we may not. Why are we so interested in knowing whether there is eccentric hypertrophy or concentric hypertrophy? Because in ECG, like if we decide to go for higher examination, higher level examination like echocardiography, we have to see and correlate with ECG findings. If ECG finding it doesn't show anything like hypertrophy, then we may not be, the measurements are taken, but we may not pay attention to that because the ECG has not shown it. But if the ECG is showing, then we have to pay extra attention to find what is there in the ECG, to see if it is there or it is a false positive. So why are we concerned with these ones? What's wrong with having eccentric hypertrophy? What's the clinical importance? Clinical importance. Another cause here, that is pulmonary disorders like COPD. It's another cause, pulmonary disorders. And then also here can cause COPD. COPD, it causes both, depending at the level, whether chronic, it is already chronic, so depending on whether there is pulmonary hypertension or not. Otherwise, it falls under both. What's the clinical importance of this one? We come back. Eccentric. Why are we concerned about eccentric? Eccentric, we can have, it can cause conduction defects, conduction abnormalities, e.g. right bundle branch block, left bundle branch block, or non-specific interventricular conduction delay. Non-specific interventricular conduction defects. And then another thing, it predisposes to arrhythmias, e.g. VTs, atrial fibrillation, atrial tachycardias, and then VF. All these ones it can cause. So all these are all same as concentric. Concentric is also going to cause the same things. But this one can also cause ischemia. Ischemia, and then systolic dysfunction, or diastolic, most especially diastolic dysfunction for concentric, then systolic dysfunction for eccentric. This one goes more to that, and then systolic dysfunction go to this side. Dysfunction. So if you find them, whether by echo, whether on ECG, you just know the patient has this risk of entering heart failure. So this one, if you combine them, you get an outcome which is heart failure. Yes. So that is done. So next is what enlargements are seen on the ECG. which enlargements are seen on the ECG. So in the ECG, we can see enlargement of any chamber. We can see any enlargement of any chamber. For example, right atrial enlargement, right atrial enlargement. You can see left atrial enlargement, left atrial enlargement. You can see right ventricular hypertrophy, right ventricular hypertrophy, and then left ventricular hypertrophy. Hypertrophy. These ones we can see on the ECG. So we are going to see one by one. We are going to see one by one. So what are we starting with? We are starting with right atrial enlargement. Very fast, because we have to see them on the ECG. In right atrial enlargement, remember the normal ECG. The normal ECG we said it has to be baseline and then P wave, T. This is what we said the normal ECG should look like: P, Q, R, S, and T. This one we said. And then we gave the normal parameters of P wave. We gave the normal parameters of a normal P wave. We said the normal P wave should be rounded. If this is our P, should be rounded. It has this dimension, which should be less or equal if it's 2.5 millimeters, and it has this dimension, which should also be less or equal to 2.5 millimeters. And we defined what a millimeter is on the ECG paper. I remember we did this ECG calibration. We calibrated it as a big box which has 5 small boxes inside. 1, 2, 3, 4, 5. 1, 2, 3, and 5. We say the small one, this small box here, it is 1 millimeter. And also upwards also, it is 1 millimeter. But this 1 millimeter upwards is equal to 0.1 millivolts. And then here downwards, 1 millimeter is equal to 40 milliseconds or 0.04 seconds. This is what we said on the ECG. So this is the calibration. So this P wave should be of this shape morphologically, and then formula, and then like dimensions. We divided this P wave into 2 parts. Like the first part is for left atrium depolarization, and then the left part is for right atrial depolarization. We said all these things. So why the left later? Because there is a node, the source of the normal impulse is in the right atrium, so it will depolarize first and then next, the LA next. So what happens in right atrial enlargement? remember, if this was the normal size of the right atrium, if it enlarges, at enlargement, it is going to be like this. This is normal right atrium. This is right atrial enlargement. What happens? We say the larger myocardium generates high voltage. This one is slightly bigger than this one, so it is going to generate high voltage. High voltage. So in right atrial enlargement, this is a normal one. It is going to turn into this is the P wave in right atrial enlargement. Very tall. So here the dimensions are more than 2.5 millimeters. But duration is the same. Duration same, but amplitude is increased. So this is in a right atrial enlargement, and it's called P mitral, P pulmonal. P pulmonal in right atrial enlargement, P waves. So causes here, we can see it in COPD, tricuspid stenosis, or tricuspid regurgitation. We are going to see it. And then in ASD with the left to right shunt. So these ones, P pulmonal, these are the conditions under which you can see it. Now we go to left atrial enlargement. Left atrial enlargement. So remember again, we draw the P wave, the normal ECG. This is a normal. Again, the labeling is that one. But now we have divided it into two. Instead of looking like this, it will change and look like, that is P. This is P. We shall get notched P waves in left atrial enlargement, notched P waves, notched and broad. So here, from here up to this point, we said it has to be SO equal to 2.5 millimeters. It's going to be more than 2.5 millimeters in right atrial enlargement, so left atrial enlargement. So this one is called P mitral, because it looks like a M, and also it is located towards the mitral valve. So what are the causes here for P mitral? It's going to be mitral stenosis, severe mitral regurgitation. Mitral stenosis and severe mitral regurgitation, they are going to cause this left atrial enlargement. But also not forgetting cardiomyopathies, dilated cardiomyopathy, they are going to cause. And then maybe shunts, the shunts like PDA, but not much. These are the most common causes of left atrial enlargement. Again, this is normal, and this is left atrial enlargement. So before we go, let's look at this normal. Their normal variants. So before we look at the normal, So it will appear like for example, if I'm to draw, if this is the normal LAE, that is the normal LAE. So if it enlarges, it is going to be bigger than this one, mitral valve. This is left atrial enlargement. Again, the same principle, larger myocardium, high voltage, but now this time around, still we can divide this thing into two. We can divide it into two. Into right atrium and then left atrium. So left atrium, left atrial enlargement, whatever we are increasing the duration. This one will depolarize normally, but this one will depolarize so easily, like so slowly, because it is big, and sometimes the voltage may be high, but it will not be altered most of the time. So here it will be normal amplitude, but here prolonged duration. Here prolonged amplitude, but here normal duration. So where, in which leads do we examine if we want to find whether there are atrial enlargements or not? Which leads are we looking at? To examine for atrial enlargements. So which leads? We're going to use lead 2 and V1, especially lead 2 and V1. And we know what is normal in lead 2. You can draw normal, right atrial enlargement, and then left atrial enlargement, and then biatrial enlargement, because we can have both when they were both enlarged. Yeah. So what is normal in lead 2? P wave should be like this. Then right in the V1, P wave may be biphasic or monophasic, but I'm going to use a biphasic one. Like, now what are these components? Remember we said the P wave should be less than. This is for right atrium, this is for left atrium. This one should be less than 40 microseconds, 40 milliseconds, less than 40 milliseconds horizontally, and this one should also be less than 40 milliseconds horizontally. But because in left atrial enlargement we say duration, we shall look for wider left atrial component and slightly deeper left atrial component. Then in right atrial we shall look for taller right atrial component. So this is how it is going to be. And P mitral, P pulmonal, we said it will be peaked like that. And then left atrial enlargement, lead 2 will be M-shaped. And then by atrial enlargement, both criteria, it will be tall this is taller than this, but wider also, like this. This is taller and narrower compared to this. These are criteria. Then for V1, it is going to be, it can be monophasic, tall, or biphasic, like this. If it is monophasic, it can be like this or like this. But if it appears like this, probably most of the time it is left atrial enlargement. So if it is monophasic, it will be, if it is biphasic, like this. If it is again another component of monophasic, it will be like this, wider component. Then for P from a mitral, it will be shorter component and then wider. And then here it is going to be, it can be naji, this is wrong. Then when you combine both combined, tall component and wide. Yes, so these are the morphologies of P waves in those pathologies. We check V1, lead 2 and lead V1. Any of those two. Otherwise, we have to look at all ECG leads.